Okay, this isn't going to work very well. So you're just going to have to trust me that if you click these links, you'll come through to a website that compiles all the data. If it worked, you'd come through, you'd see a UK map and you'd see across the country where cases are being reported. And so if you want to follow in this level of geekiness, you can. Johns Hopkins is good, Worldometers. It breaks down the data by numbers of deaths per country and then deaths per, but not just the numbers, but by per 100,000, etc. So starting at transmission, this study at the top here is the one that the early news reports really were referencing. And it talks about the different droplets compared to SARS-1 and SARS-2, and then they tested droplets on aluminium and on copper and on hard surfaces and on clothes. And so this is the data set that tells you how long something stays infectious for on different surfaces. And the bit that doesn't often get reported is the volume of infectiousness of these droplets, and it definitely dramatically drops. So although on a hard surface you're going to be able to get infectious virus, 2 days later maybe, if it's on steel, then the amount of infectiousness is definitely dropped dramatically. The next link is to a study which gives you the data on why we have this risk period for 5 days and why we've got in isolation for 2 weeks. And there, although it's quite comforting that most people have in symptoms, become symptomatic within 5 days of becoming infected, there are cases there at the longer extreme where people don't get symptoms for 2 weeks or 3 weeks. And so generally we're all making population-based advice based on the average, but be aware that there's odd cases where your risk might have been 2 weeks ago and now you get fever. You have to take that seriously. It's not that you've gone past the 5 days and that you're safe. So the 4 papers that are linked here on transmission use different extremes of the spectrum to show you your risk. So some of them were I mean, this is amazingly carefully done research, but they would look at the first doctor, for example, who became positive in France, and they tracked everybody that doctor had come into contact with, and none of the patients or staff or people that he lived with turned out to be positive. So you have optimistic studies like that show that transmission isn't necessarily guaranteed just because you share living space with someone. And there's another example there, which is the opposite. It sort of shows that the highest risk is to be sharing a living space with someone, and that's when transmission is most likely, mainly because you're there for a longer period. And for health workers, you're in situations where you definitely know people have COVID-19 and you're having a high exposure to that day after day, and that's why the need for masks and protection is so important. And then right at the bottom, just to make everyone a little bit jumpy, it's worth going through. There was a report that shows that it's not just coughing and sneezing, but actually just sharing the same environment with somebody who's just breathing, and the droplets can be recovered from people that are just from normal breath, not the sneezing and coughing. And so really that sort of emphasizes why masks might be useful in all settings. Any questions about these?
Yeah, Simon, this is great. It's Roy here. I've got a question.
Yep.
And so it's interesting about the contagion through speech. So I was in the supermarket this morning. There were 2 young guys who were moving the trolley across, and they were having a really great conversation. They were laughing very, very loudly. Yep, risk, definitely. Yeah, and I think that, so the idea of wearing a mask for that, do you think that's a good idea?
Yes, definitely. I've got a mask slide right at the back. I think masks are a good idea, and there's a few cautions to do with that. I went to Sainsbury's yesterday and someone was singing, yeah. Not a great idea. You saw that the US study where the choir decided that they would still meet, a choir of 100 people, and the next day, next week, 50 of them had all gone down with COVID, positive for COVID infection. So singing and talking and laughing, all risk factors. Okay, so this is the slide of viral shedding. So just like HIV, the similarities between COVID-19 and HIV are very good in terms of having a medical understanding of what's going on. So viral load, they're not testing viral load in blood, they're testing viral load in the throat. That's why people are having swabs, nasal swabs, throat swabs. There's going to be a saliva test. Saliva is highly infectious, probably more infectious than blood or any other fluid, because this is a throat infection. And you can see the days since the onset of symptoms and viral load here. So you can see viral load stays high for 2 weeks maybe, since the onset of symptoms. And you've got a mixture, I don't know if you can see it, they've got throat swabs and nasal swabs. Doesn't seem to make much difference to me, but you can see after 2 weeks, there's very little viral load. So this is why you're being advised, we're all being advised to isolate for 2 weeks if we're with anybody who tests positive or has symptoms. So here, just, I hope everybody knows this, 2 big symptoms: high temperature. This is based on NHS website. High temperature, you don't need to have a thermometer, you just need to be hot to the touch. And you'll know it if you have a temperature, because it will be persistent, it will stay there. And then especially if you have a continuous dry cough, not a phlegm cough that's producing anything. And then there's a little bit more definition here, if it's persistent, if it's going along. And then you saw that we distributed we're putting together a community survey, and we're including these as other symptoms in the community survey. And so there's other things that maybe the more of these you have, the more likely it might be that you might have COVID-19. The loss of smell or taste is definitely a recognizable symptom now. There's been a few papers about that. But any of these general flu-like symptoms in the context of having a high temperature and a cough makes it more likely that you take this any of these symptoms, take them really seriously. Don't go out. Any question about symptoms? Okay. So this is the slide earlier from China. You can see that this is a percentage going up here. 100% of people don't get a fever, and 100% of people don't get a cough. So this is the people that have COVID-19, but they're lucky and they don't get symptoms. And then you can see that cough is maybe half the people that were diagnosed with COVID-19 in the China study had a dry cough, and then everything else much lower levels, 10-20% for these other symptoms. If you get these symptoms, I thought it's important to put this in just so that we're all up to date. Look online, and there's a symptom checker, and it will take you through, and it will sort of gauge your level of seriousness. Sorry for my spelling mistake, Roy hasn't proved this yet. If it's a medical emergency, the first thing is you've seen on the news reports that people aren't going to A&E, they're holding back from A&E when they're having heart attacks. You have an medical emergency, phone 999 as if it's not COVID-19. But anything else, go through the symptom checker. The symptom checker will tell you when you need to phone 111, and the person you speak to there should hopefully be better at putting you into care if you need to go to self-isolation or if you need to go to hospital. Any questions? Has anybody phoned 111?
I was going to say, I did go through the symptom checker when I had symptoms.
Yep.
What was odd about it was after I'd spoken to my HIV doctor, so she'd already told me I'd probably got COVID. And there wasn't really a way to say you'd already been in touch with services to find out what to do. I mean, I can see the purpose of it, but it was very much geared up for people who had had no NHS contact beforehand. The symptom checker. It did advise me to ring 111, but I didn't see the point as I'd just spoken to a proper doctor. Sorry, that's unfair.
We also have a comment from Josh, who says she spoke to 111 and to PHE team when she had it.
Okay, that's good. So the next thing I put in was just so that we as a group, Let's keep an eye on the time. That we as a group understand the different stages for COVID-19, and that will help also understand some of the responses for treatment that's being suggested. And so to this report here links you to the article, and the early stage is about, it's a week where you're infected, and then a few days to get symptoms, and then the infection, it's very local. It's an infection in your throat, and it's quite localized there for about a week. And if you're lucky, that's where it stops, and it's mild, and you have some uncomfortable symptoms. If it progresses, then it moves from your throat down to your upper lung, and then eventually down to your lower lung. And so once it moves to your lung, it still becomes a viral infection. So viral load, if you were able to test tissue in your lung, would likely to have high viral load levels in your lungs as well. But then what's happening is it changes. Although the virus is there, your immune system has a sort of severe response, and it produces all sorts of chemicals, and you have something called a cytokine storm. And these levels of inflammatory cytokines, things like IL-6, for example, go 10 times the height. So your immune system is fighting back, and then all the damage that happens to your lungs doesn't seem it's because of the virus. It's because of this immune response.
I saw Simon. Josh has a hand up.
Yep.
Yeah, it was the upper respiratory tract that was most affected with me, Simon. And I had a steroid inhaler, which did help. But when I had it, it was such early days. It wasn't called COVID, it was called coronavirus. When I called 111, I was the first person that they'd spoken to in my particular area. And PHE were deciding who they contact trace, but were only contact tracing and testing anybody who had had 15 minutes confirmed contact with someone who was confirmed to be a case. And as at that moment, there was only about half a dozen in the country.
Yep.
They'd only tested 138 people. So I don't think my experience would be in any way representative of what would happen now.
Okay. So you were lucky if it remained just to your upper respiratory tract. The issue about steroids is quite controversial, actually. If it becomes a lung infection, then generally they're not recommending steroids unless there's a principle is if you're on any other medication, including HIV medication, don't make any changes to that. Don't stop, don't change HIV meds to other meds that might help. Just stay stable on everything, including if you're on blood pressure medication, continue on blood pressure medication. All those things are important. So the second stage here, we've got this.
Sorry, Simon, can I just there's another question from Ben Cromarty.
Yep. On
hypoxia. She says some people use the finger thing that measures percentage of oxygen. What is the level that would cause alarm?
That's a very good question. It'll probably come on the instructions. Probably anything less than the 90%. I would imagine. When I see the studies going through, they're using cutoffs of less than 95% or 90%, and so there's a little gadget you can get from YouTube and not YouTube, from Amazon, and the problem with the specifics, the reason this isn't normal influenza is that in the second stage, when your immune system is going into this overreaction and it's generating lots of dead cells and lots of mucus, this is what fills up the lungs and makes it more difficult to breathe. And so instead of your lungs being like whipped cream, this is how one study described it, instead of it being like fine whipped cream and the air goes smoothly through from your lungs into your blood, it steadily becomes thick like marshmallow or treacle or something. And so the problem with the lungs is it's stopping oxygen getting into your blood. And then the final stage actually is when this has become so severe that you have major organ illness. It contributes to heart disease and heart problems, or you need to be put into a coma in order to have mechanical breathing. and so each stage is progressive, and if it becomes more serious as it progresses. But the main point from this slide is that the viral infection that caused it isn't the cause of the serious outcomes. The serious outcomes are caused because your immune system has this inflammation response, and your body's sort of going crazy with these cytokines.
I wanted to ask something. I noticed you said about maintaining or being stable on all your treatments. When I was ill, there was quite a few reports, some of which you put out, some I saw elsewhere, which talked about non-specific anti-inflammatories. And there seemed to be some saying they were great and some saying they were terrible. Does any kind of resolution come about? Do you just stay on what you're on, or? The resolution is that if you're on something for medical conditions, to stay on it. There were concerns about ibuprofen rather than using paracetamol. They don't seem to be substantiated in terms of problems there. There's WHO guidelines recommend against corticosteroid treatment for the pneumonia. And so there's some guidelines on that, but steroids are still being used. When I get to the treatment, you'll see what a mess it is. You know, the risk factors that we need to be cautious of: older age, male sex, other health problems. Many of us have got these problems. We have these histories. It's not sort of a history of cancer or a history of heart disease. If you had a heart attack a few years ago, then probably it's not a high risk, but ongoing other illnesses. The medical term for illnesses is comorbidities. And different guidelines, US guidelines include HIV, BEVA statements and EAC statements. You know, there's been about 5 or 6 statements put out in the last month or so, last 2 months. And now there's sort of consensus that if your CD4 count is less than 50, then that would put you at a reason to self-isolate. And it would be extremely high risk if you're HIV positive. This was the China study, just so you can see it in more detail. You can see that the yellow line really shows that the increase of fatality gets much higher with higher age. So what do we know about HIV co-infection? So the first study was, actually this references a letter that some HIV doctors wrote to the BMJ, and I was included in that, just saying the importance of making sure your HIV status is recorded if you're admitted to hospital, or if you're reporting that you've got COVID-19. If you test COVID-19 and you're self-isolating at home, make sure there's a note that your doctor knows that you're HIV positive. First data, as with everything, came from China. The researchers phoned up 2,000 people in 2 provinces in Wuhan city who were HIV positive, and they just asked them about symptoms. And it was the first positive, optimistic data. They weren't finding that lots of positive people had symptoms of COVID-19. It's not a perfect study. They weren't testing people, but they only found about 6 or 8 people, or maybe I can't remember. Maybe 6 or 10 people were positive out of 2,000 that they tested, who were HIV positive. So they weren't showing that HIV positive people were overrepresented amongst people who caught COVID-19, who had COVID-19. And there's a case study of about 500 or 600 people from Barcelona, of which 5 people were HIV positive, and they had various risk factors. Some were sex workers, some were one person reported going to a chemsex party the week before, and that sort of can get taken out of proportion and say that must be their risk. But it may have caught coronavirus, when they went to get a packet of cigarettes or something, and the tobacconist. So we don't know. None of this data is important. There was a New York, is confirmed, there was a New York database that was reporting on 6,000 people that were being treated in outer New York, of which about 43, I think, were HIV positive. And the most positive thing that you can get from this data is to know that HIV positive people are at risk for COVID-19 and coronavirus, because very early on there were anecdotal reports saying we don't think HIV positive people are at risk, and maybe their HIV drugs are protecting them. So there was a flip thing, not just concern that we might be more at risk, but there was a
suggestions that we might be protected in some way. And this data basically shows that being on treatment doesn't stop you from becoming positive for coronavirus or progressing to having COVID-19. And COVID-19 is the AIDS version of the HIV. HIV is the virus, AIDS is the illness, and COVID-19 is the illness associated with coronavirus. So iBase has got an online Q&A about lots of different things to do with HIV and COVID-19, and the question that's been updated maybe 10 times since we posted it, because we always reference guidelines, is ended up on this consensus that if your CD4 count is above 200, then you follow the population advice. But the other thing that's happened over this consensus becoming about HIV positive people being similar to the general population is actually the risks for the general population are now seen as much higher than they were when this advice was first being put together. So this advice was being put together before we had shutdown. This was before 23rd of March. And you can see from the news reports now that being just a member of the general population isn't particularly calming, because you see that people of all ages are losing their lives to COVID-19. So it's incredibly difficult for everyone, including children. So there are some treatment guidelines online. These are where you link to them. The two most significant ones really are from the US. The IDSA, I would have enjoyed clicking this link through. The IDSA, Infectious Diseases Society of America, have they include 7 treatment options, first-line therapy. They all have the same caveat. There's no data in any of them, only use these options in presence of a clinical trial. And some of those include treatments that may or may not work at all. Similar, the US interim guidelines, these are the same group. This is DHSS, which is the group that puts together the HIV treatment guidelines. So these are the most HIV specific. And then WHO have got guidelines on all sorts of things. BMJ have got a resources page. Medscape have got a resources page. You can see all sorts of guidelines. Most of the UK guidelines seem to be for healthcare workers, protection of transmission. Nothing, I couldn't find anything about treatment. So the range of treatments that have been proposed, if you look at clinicaltrials.gov, you'll see that there's more than 1,000 studies that are ongoing for treatment for COVID-19, and they cover things like HIV drugs, Kaletra. The people from the Spanish cohort were switched to Kaletra. Their HIV drugs were switched to Kaletra because there was a thought that this might help based on results in test tubes, but it didn't work at all. So the Kaletra studies show this doesn't work. Other HIV drugs are unlikely to work. Remdesivir, we're going to talk about specifically. Lots of references to hydroxychloroquine. Not a lot of evidence that shows it works, but the US treatment guidelines have this as first-line therapy. They're looking at anti-inflammatory drugs. They're looking at plasma, harvest plasma from somebody who's had a good reaction and see whether you can use that as a treatment, and steroid treatments. Very little shows that it works. I thought that because we, in the UK CAB, look at data, and this is really topical. Yesterday this made the BBC News, and can you see my whole screen?
Yes.
Okay, I can't. So Gilead have got a drug called Remdesivir, and in test tube studies and in animal studies, it's active against coronavirus, and it's active against MERS, and it's active against Ebola virus. So it's a broad spectrum antiviral drug that seems to work against these sort of viruses. And it wasn't successful for Ebola virus, so it was just one of the drugs that was sitting there looking to be repurposed. And it was active against SARS too. And so the first antiviral drugs were using Remdesivir, including a couple of studies in China, and there's now about 12 studies ongoing. There's some in the US. There's 15 UK sites doing phase 3 studies with Remdesivir. And I haven't included the link here, but iBase has got a link to all those sites as well. And so this is the experimental drug that you're likely to get access to, maybe. And yet there's very little data to show whether it works. The first study that came out was published in the New England Journal, and it was from compassionate access use in about 50 people. And what you've got, the natural stage of infection is you get infected, you have illness, and then you recover. And we remember that most people are going to have mild to moderate illness, and then they're going to recover. And so you give somebody a drug, and you don't know whether it's actually causing them to recover or whether they would recover anyway. And this expanded access program was giving remdesivir to people who were already sick, and some of them got better and some of them didn't. So it really just told you that it's not a wonder drug that will save you, will save everyone, and that it's also maybe doing something or maybe not. There were then 2 data leaks. There was, pretty soon after this came out, by coincidence, there was a phase 3 study where one of the investigators on their trial meeting said, oh, we're having wonderful responses. We've had 300 people using remdesivir and everybody's been discharged. You know, completely unethical, and it was reported as positive news for remdesivir, and Gilead stock shot up. You know, and this was released just after a negative report showing that it wasn't doing very, very good. So the timing of all this is very sort of dodgy stuff going on. And then last week, the WHO posted this study before it was peer reviewed, a summary of this study online, and then quickly took it down again. And it was reported it was one of the Chinese studies using a placebo, and it showed no difference of benefit of using remdesivir. And so part of the complications in the studies that show no evidence is that these studies are in people who are already hospitalized. So they've had symptoms for usually 8, 10, 12, 14 days, and they're progressing from a viral infection to this inflammatory infection. And so there may still be a benefit of using an antiviral drug when you're reducing viral load anyway, but it's not the cause of the damage. So this is why it's very complicated to interpret the results from these remdesivir studies. When this study was published yesterday, or 2 days ago, in the Lancet, so it's been peer reviewed now, there's a figure there, and this is your homework really, is click this link, go to the study, look at figure 3, there's 2 viral load slides, and the viral load slope decline is exactly the same in the placebo group as in the active drug. And I just want someone to explain this to me. If you're giving somebody an antiviral drug and the viral load measure that you're using doesn't change, that's not a great indication of activity for me. However, you've got this large ongoing US study, which is also randomized, and it was the results were announced by press release. We don't have any details of this study, but it was rushed out. You know, the US has 60,000 people have died in the US. You have a president that says you should be taking Dettol or antiseptic, or who announced hydroxychloroquine would work, and suddenly all the supplies of hydroxychloroquine disappeared, and people who needed it for lupus couldn't get their treatments. So there's political healthcare issues that are going on all the way through. The NIH statement yesterday from Anthony Fauci, which was on TV, was reporting early data from this study, was saying that people that got remdesivir recovered 4 days earlier than people who didn't, and that was significant. But we don't have any other data. We can't dig around in the data and find out maybe where people who got remdesivir were maybe not quite as ill when they got remdesivir. So you've got this tug of war going on. Gilead, and I'm not saying this isn't a conspiracy theory thing. I'm saying that you've got a company here who is very good at bringing drugs to market. So they may have a really good drug. And behind the scenes, Gilead have put out various press releases about how they're giving away all the drug as soon as they can make it, and they're committed to the research, and that they're ramping up production in the expectation it might be good, and that by the end of the year they might have 1 million courses to give away free. They're sort of caught in the middle of doing this thing. The data isn't that clear, and it's complicated to interpret, but the data I've seen in the Lancet wasn't particularly good, or the New England Journal, then you've got this press release from the NIH that says it might be better. So it's sort of follow this news. Within 2 weeks, we should have better data. More data from this study, for example. I realise I talked quite a lot about Remdesivir. Are there any questions? Did that make sense? Everyone's quiet. All right, so hydroxychloroquine, there's definitely been studies showing that there was an early French study here, Guatre here, I might have spelled it wrong actually. So it was a strange study that reported a benefit from using hydroxychloroquine and an antibiotic as a treatment. And if you pulled the study apart, some people were very unhappy with that study. But on the basis of this, hydroxychloroquine studies were launched everywhere. There's a no benefit of hydroxychloroquine study, which was done by a French researcher called Jean-Michel Molina, who many of you know because he did the Epidemiology PrEP study, really good French doctor. He's not convinced there's any benefit at all, and he did a study in about 12 people and found no benefit. There's also studies showing that higher dose chloroquine or hydroxychloroquine definitely is associated with risks. It increases your heartbeat and a risk of heart disease, and so it's not a drug that's without risks. I included this slide. People at highest risk, really, of catching coronavirus and COVID-19 are health workers. And so there's about at least 50 studies that are listed on this clinical trials website looking at all sorts of things, maybe 100 studies for prophylaxis. 80% of those are using hydroxychloroquine. Some of them are using Kaletra. Some of them are using tenofovir and FTC because of test tube benefits, even though they're not very strong. So this is 4,000 healthcare workers in Spain, and there's a placebo arm, there's dual hydroxychloroquine and Truvada, or there's just TDF FTC. All these drugs are being used as prophylaxis. Masks, I think I must be getting to the end. Whether we should wear masks, I sort of come down on the side that they're beneficial. Really early on, when there was limited supplies for masks, then you wanted to make sure healthcare workers could get them. And since then, there's been all sorts of other bits of research showing that even though homemade masks aren't as good as medical masks, they still will protect, maybe instead of catching 95% of bugs, they might catch 80% or 50% or something like that. And so there's the social benefit actually of showing that you're aware of what's going on. There's the accidental benefit that you might sneeze or cough before you put your arm up to catch your cough. And so I think that they're generally a good idea. There's people making homemade masks all over the place. Dual fabric is better. If you hold them up to the air, to the light, and you can see lots of pinholes, they're not going to be very good. So use fiber that's quite close knit. There's lots of information about where you go from here. This is just a snapshot where I've tried to do my best to summarize things. This is a good webinar from the IAS. Both these pages here link to maybe 10 other webinars that are ongoing. Some of them are community websites, some of them are community Q&A sites. So there's the IAS website, there's the ITPC website, which is HIV organization. And so click through, see some of the followers of the links pages. And that's my slides. Great.
Thank you, Simon. We have about 13 minutes for discussions and questions. And I think you can unmute yourself and ask a question.
Hi, Simon. Thanks so much for that. I just texted a message just in relation to masks. I'm assuming that the main benefit of using a mask is going to be when you're in more confined spaces, or when there's more people around. So it's in close proximity, in closed spaces. It's not for walking to the shops, but when you get into the shop, unless obviously the streets are crowded. Is that the right approach?
So the first reason to use a mask is because people that are either pre-symptomatic or are asymptomatic, and whether it's you or the people around you. So you might already have coronavirus and be and be asymptomatic, but still be infectious, during that 2-week period. And so you're sort of protecting other people, and you're also similarly other people, you're protecting yourself a little bit there as well. And then the hanging around in air bit it's as cautious as you want to be. And there's a line between caution and paranoia, so I know people that definitely put the masks on as soon as they leave the house, and they're not quite wearing it around the house yet, but maybe if one of you was diagnosed, you'd wear a mask around the house. You'd both wear masks, or as many people that you live with would wear masks as well. But yes, you're right. It's walking in fresh air is supposed to be is a very low risk. And I also read something that the actual droplets as well, they repel as you move through the air. You're actually pushing the droplets away. You're causing air currents that move things.
Andy has his hand up.
Yep.
It's a comment about death rates that I've heard from a couple of different sources, that for a given age, the rate of death with COVID-19 is about the same as that if you catch the virus, it's the same as the death rate over 1 year. That for your age, that is, if you're, for example, a 50-year-old, with the chance of dying within the next year is 1 in 500, then for a 50-year-old, if you catch the virus, your chance of dying is 1 in 500. So in other words, I think that's a good thing to bear in mind, and to allay fears about dying from COVID. That obviously for an individual it doesn't make any difference, but from a population sense, whatever age you are, if you were going to die this year, then that's the same rate the chance that you will die with COVID-19.
Maybe. So I don't know the study. You might well be right. You might. I prefer to look at risks depending on your level of symptoms. So not just the catching of the infection, but the mortality. The really serious outcome is if you die from this thing, and that is related to whether or not you're hospitalised. If your symptoms are bad enough to be hospitalised, then that's your serious risk from mortality risk from COVID-19. And there, age makes a huge difference.
Yeah.
So if you're over 80, then it's probably 1 in 4 chance of not coming out the other side.
Yeah, and that's the point, Simon. That the shape of the curve with age.
Yep.
Actuarians do those calculations for life insurance for the chance that you will die within the next year.
Yep. And
the shape of that curve is more or less exactly the same for COVID-19 if you catch the virus.
Okay, so there's a good point. It's nice to be reassuring to people as well. Yes, and if you're coming from that perspective, the 80% of people that are going to have mild or moderate symptoms is good to know, and the 15%, it's just 5% of us that are at risk.
Okay, we have 2 more questions before we. So, David, Andy, are you finished?
Well, I'm just going to say, contrasting to, for example, HIV with no treatment. If you catch HIV and you don't have treatment, you die 100%. COVID-19 isn't the case. If you catch COVID-19, there's a very good chance that you won't die, but it does get worse with age. Yeah. The same as the chance of dying gets worse with age.
The difference is the acute. Everything with coronavirus and COVID-19 happens within a few weeks. Yeah. Everything with HIV, what you say might be true, but it's going to take 20 years.
Okay, we have 2 questions from Damien and Bibiana. So do you want to ask them all together so Simon can answer them together? Or?
Yeah, just very quickly, just picking up on that point. I don't think we can say what we've just said there, Simon, because this virus is so new. We can only say that we know what we know about it now and the impact it has now.
Fair enough.
We don't know what it's going to do in 5 years' time.
No, fair enough.
A couple of other things. I think we need to start looking at HIV treatment. Is it offering some protection? I think potentially, yes, it is when we look at the global figures of where infection rates are occurring. Earlier on, you mentioned the choir singing in America, and within days they were all infected. There was also the big gay thing in Miami where 30,000 gay men convened on Miami Beach, and there has been maybe 5 or 6 reports of people contracting corona from that meeting.
So tracking down the data is difficult. I've seen, I was in Miami at that time, and 5 people from one party are dead now.
Out of 30, yeah, I mean, it's out of 30,000 people. So I think when we were looking at the big cohorts yesterday, I think you said there's 17 or 18 people in London.
So the UK database has at least 50 people who are HIV positive and co-infected, and it looks like where you'd look at that and then the population, it's about 1%. 1% less than 0.5% to 1%. So we're roughly reflected at the same percentage that HIV is in those cohorts. I'm not seeing evidence of a protective effect, but you're definitely better if you're HIV positive. Then absolutely you're better off on treatment. But I don't think being HIV positive people on treatment are better off than the general population. But open to research.
Yeah, I mean, I think Julia Delarmo's in Madrid. She will come out with this. So you had that on your slides about the Spanish healthcare workers. I think it's important just to say that Julia is reporting every 3 weeks on this trial. She's not waiting till the end.
Fantastic. Every study should be reporting almost in real time. The frustration I have with Remdesivir is these studies have been going on for several months and we don't even have any viral load data.
I completely agree with Remdesivir. I don't think that's the option here. But just going back to the swab thing, I think we need to be going more into swabs as well. There's a lot of evidence that says there's rectal shredding going on. And there's people now calling for people that have cleared this virus in hospital to have a rectal swab before they leave hospital.
So I can give you up-to-date data on that because I was reading that beforehand, is that the viral infection, after it's cleared here, is still detectable in your poo for a couple of weeks.
Yeah. And is this a transmission route? Which brings me on to, is this a sexually transmitted infection? Because I know very few people that have sex without kissing. So
the highest risk is saliva, because saliva is highly infectious.
Yeah.
So that's what I watch out for. If you've cleared the infection, then you've definitely had COVID-19. Your viral load has been high here. It's now negative on a PCR test. Not going near the antibody test at all.
Yeah. Negative
on a PCR test, then parts of your body might still be infectious. That's why it's sometimes recovered in fecal samples.
Yeah.
And so still be careful. Don't assume you're completely uninfectious just because you have a negative throat swab.
Yeah. So moving into the new world that we live in, is what are the discussions that we now to start the wider population to be having about what is safe and what is safer? And the gay community have had this conversation for many, many years now. And how do we kind of link this into a wider population discussion?
So at the moment, I'm quite happy for this to run over if people want to carry on talking, because it's the first time we've had the chance to talk. So to break this down, there's several things going on. One is the public health response during this acute, short defined period of several months, and advice for sort of not random sex, but hookups, or for people who are not in relationships or sexual relationships with steady partners, where you've got this arrangement that you're both self-isolating or you live together. Or everyone else, gets the rough end of the deal in terms of what happens to your sex life, and so some people are still having sex, and some people are still hooking up. Some people still need HIV testing and STI services, but generally speaking, the advice for no hookups until this is over, sort of controlled, is the best advice, based on not on protecting the NHS. Don't care what your sexuality is, or what your use of recreational drugs is, or what your need for sex is. It's the same advice across the board that actually, or if you're a sex worker.
Yeah, we can. I mean, we've lived through this epidemic, Simon, where we've said don't have sex until you've been tested, but people still have sex. So I think we need to confront the new world, and the new reality is that we're not going to get on top of this in the next 6 months. Well, and we cannot expect people to stay
I'd be more optimistic that if you're looking to countries that are a few weeks or months ahead of our particular curve, that social isolation is being relaxed and some shops are opening and some returning to normal is happening, and people organically will be making units of closer social contact based on the fact that they trust each other not to have had other risks in the same way, I guess, as HIV. So these things will change, and we luckily, UK didn't learn anything from being 3 weeks ahead of Spain and Italy, or being 2 months ahead of China. This is the big scandal, the big political scandal is that 30,000 people have lost their lives in the UK because we've got a government that couldn't get itself together to either stop the flights at the right time or get face masks for healthcare workers, etc., etc., etc. And so we can learn from what's going to happen in Italy and Spain. They're slightly relaxing now, and we'll have an idea. In Germany, they're slightly relaxing, and we'll have an idea of whether second epidemics do happen in practice, and that's how we'll learn. So I wouldn't make any comment about 6 months now. I'd say, let's see what happens in the next month in other cities that are relaxing.
I think we've already seen it in Germany. They've seen an increase where they've relaxed the interactions. They've already seen an increase in new infections. So I think it's good to say, yeah, let's be optimistic, but I think we have to be live in reality as well.
So saliva is your highest risk. So your risk from sex is from saliva.
I have a question from Ben Cromarty, who's asking that South Africa seems to be doing very well with COVID.
Yep.
Surprisingly, any thoughts as to why?
I think they did very close contact tracing and symptom testing and contact tracing. I think that's what happened very early on. But I think, watch this space for all these things. I don't know how it's going to play out in South Africa or in other African countries. Like I'm on
Nigeria.
I'm on a similar list with memory with African advocates, and it's really heartbreaking because 2 weeks ago people were worried that they were reporting single figures, and then last week they were reporting double figures or triple figures, and now they're reporting deaths in the network of activists that we know. Mm-hmm. And so I find it difficult to be optimistic, including in South Africa. I can't see how South Africa is going to have an amazing response. But I hope I'm wrong.
Okay, any more questions? I've just sent a message to everyone saying that I'll be sending out a small feedback form. It won't take you 5 minutes to complete. If you could please complete that and just send it back to us so we can see how best we can improve on what we're doing now. Big thank you to Simon.
Memory, can I just have a very quick question? And it's to everybody really. The research that's currently going on, are there community representatives on these research things?
So some of the HIV groups are including community. So that this survey we're putting out with the UK CAB includes people from doctors that have come to and give talks. Caroline Sabin, Laura Waters is contributing to both those things there. There's some research that's looking about linking up HIV databases with the intensive care databases. That includes some community. But in terms of the phase 3 studies of hydroxychloroquine for the general population or for Remdesivir for the general population, I don't think it had any community input at all.
Do we not think it's about time that we started to really almost demand?
Absolutely, that could be offering to be community places on anything to do with research to do with COVID-19, I think. And so in terms of the feedback, please do use the feedback link memories things, because I just had an intuition that us talking together would be a good thing, and we can do this. It costs nothing. We can do this at any point, and we could even just do an update on the research that happens once a month or once as people need it. And other people can lead the meeting. It doesn't have to be me leading this. I've just been tracking the research quite closely.
So any suggestions that people might have about the meetings might be helpful. So I just noticed that I had packed a question from Ben Cromarty again about blood pressure and blood pressure meds. Are they good or bad? Ben, do you want to expand on that? Ben Cromarty?
Sure. Yeah, so hypertension was one of the risk factors, high blood pressure.
Yeah.
And there was some, I was confused about whether some of the treatments, the ACE drugs, were either good or were bad. There seemed to be some conflicting evidence.
So early on, there was a concern that ACE inhibitors may make it worse because they bind in the same way that the virus binds, and so you might have a higher risk of infection. But if you're on ACE inhibitors or other hypertension drugs for your own health, then the advice is very clear. Don't stop those drugs. You want to make sure that your hypertension is controlled, and that if it's controlled, then your risk is just like if your HIV is controlled or if your heart disease is controlled, then you don't bump into a higher risk group.
Thanks.
Any more questions? No? Okay, thank you everybody for coming together again, and we hope from the feedback from yesterday and from this meeting, we'll determine what we discuss next, and we'll always get in touch with you about dates and maybe topic suggestions as well. And have a very nice weekend.
Thank you, Henry, for organising this. I was going to say one other point, actually, just in terms of Damien's suggestion. So anything that's going out recommending how people have sex or how we deal with this practically, that's a community-based project. We need to be involved in that. And people that do prevention work are the experts here. You know, I saw that the NHS is looking for sexual workers, people working in sexual health services to help with contact tracing, because these people are used to talking to people nicely in a way that doesn't make them feel like they're being victimized or tracked or something. So
that's really what I was saying, Simon, earlier about as a gay community, as LGBT communities, we've had this conversation for so many years now.
Well, as an HIV community, which is much broader than LGBT community.
Well, yeah. Sorry, yeah, but I'm just as an HIV community, yeah.
Okay. Memory.
Yes.
Do we have the option to run over and chat if people wanted to carry on chatting?
I actually booked this for half an hour. I made that provision. We have 25 more minutes to go if we need to.
It doesn't cut you off anyway if you want to continue. I don't.
So I can hang around if people still want to discuss, and I understand that people are also very busy, and that if the joining for the hour was fantastic. It's really nice to see everyone.
Thank you. I have to go. Thanks, Simon.
Bye.
Thanks.
Thank you.
Have a lovely weekend, everyone.
Bye. Bye. Thanks, Simon. Thanks, Memory.
Thanks, Damien.
Thank you.
Bye.
Great to see everyone.
Bye.
Mel, do you have a question? Mel, I'll unmute you.
I think she's.
Has she gone?
I thought she'd gone.
Mel.
I'm still here, but
hello.
sorry, I don't. No, I don't have a question, but a lot of appreciation. Thank you. That was, yeah, as always, Simon. Scary, but solid information. Thank you.
Good, thank you.
Just on the prevention angle, so whilst I chair the UK CAB, I also work on the HIV Prevention England national programme, and we're in conversations with PHE around messaging going forward. Obviously our usual campaigns will be changing. There's still a kind of a discussion going on about what that looks like. You might have seen organisations like PrEPs do a kind of sending out some sort of like harm reduction narratives and stuff, which I don't want to dismiss, but at the same time, it kind of, I think you mentioned it earlier, Damien, like if someone's choosing to hook up with someone else, they've decided, they've got their own risk perception, they've decided it's worth risking that. So are they the type of people who are then going to get there and then not kiss that person, for example? Or are they the type of person who's thinking, you know what, COVID-19 is not going to get me anyway, so I'm going to hook up with someone and do nothing to normal? It's that balance. So there's a lot of community surveys going on at the moment. The GMI partnership in London are doing one. There's one through Westminster University, there's another through Manchester Met, and they're asking people all these questions, and we should be getting data from them this month, like in May. So we'll be able to use some of that information as well to kind of work out what people are actually doing, and then we can build there from what information we need to communicate as well, because it will help us inform that messaging and the narrative.
I think one of the big things is what questions should people be asking each other?
Yeah.
So something as crazy as when did you last go to a supermarket and how close a contact did you have?
Yeah. And it's this thing again where there's actually these parallels with sexual health and HIV.
Yes.
People will lie, people won't tell the truth, people won't be honest, people won't ask these questions. And people will say, oh no, I'm fine, I've not had a cough, I've not had a fever. And people will take that risk and meet them in the same way that when it comes to HIV, people are like, oh yeah, I'm fine, like I don't have it. And never mind asking them when they last had a test, and it could have been a year, 2 years ago, people still take that risk. It's the same with COVID-19. We're seeing the same patterns.
Yeah, and I think if we look at how the communities responded to HIV, and to find the hard to reach, particularly hard to reach populations, and I think we can already start that with COVID now. So people like your barbers at the minute are closed down, but the reality is people are still getting their hair cut.
Yeah.
So barbers, hairdressers, nail salons, we know that these are operating, but they're operating under a closed banner. But if we could go into these places and start to say, you need to have this conversation and these are the questions, I think we're already on top of, we're already kind of 5 years ahead of where we were with HIV when we started looking for the hard to reach populations.
Yeah, I think that's true to some extent. That's a really interesting thing to think about as well.
So I think everything you're saying about finding out what's really going on is essential before you know what you can do and what you shouldn't do, and that the bit that I would input on is whatever someone's doing, they need to know that saliva is the risk factor.
Yeah.
Because immediately people said, well, is it safe sex? Is it sexually transmitted? Well, it's sexually transmitted if you're coming into contact with saliva, which isn't all sex, but that does change how you then have informed sex. Just actually in HIV and STIs, somebody saying, oh well, I'm a happy-go-lucky person and it's either going to get me or not, will behave differently if you say, by the way, you can be as happy-go-lucky as you like, but do you realise the risk is saliva? They will change what they do.
Mm-hmm. Well, they might do.
Well, they might do or they might not, but there's a good chance that understanding known risks is important.
The thing for us that we're really conscious of is that it's taken years, decades to get to this point with HIV in terms of changing behaviours.
Yeah.
And some of that's to do with people's behaviours, and some of it's within like the systems, like the health system. The increasing testing, for example, when it comes to HIV, and we've not got as much time when it comes to COVID. We've got to kind of get people to act and change their behaviours now, and it's not, behaviour change isn't something that you can do overnight.
No, but hopefully we're not talking about this for the rest of your life. We're talking about, if we're being optimistic, it'll be a vaccine. Short period of time. There was I'm on a chemsex list where someone posted a photograph that had been taken of a note that had been put in the lift for the building, and this was in Spain. And it said, to the occupants in flat number 47 or whatever it was, please can you not have your friend visit, new friends visit every day. We think we should possibly delete Grindr.
But
Wow.
Alex, can I pick up on something what you said? Because I think if we look back historically, it can lead us in a direction in the future. Historically, it was very hard to talk about sex and sexuality and sexual practices.
Yeah.
Today, many people will very openly discuss sex, sexuality, and sexual practices, much more so than they did 20 years ago. So we're already at a head start here, particularly with younger generations. They're very, and even to some extent, older generations now. So I think we're already got a head start there.
Yeah.
I know we'd like to all be really optimistic and say we're going to get a vaccine within 6 months' time, but we're not. We've already got 8 or 9 different strains of this, and it's mutated 29 times. We're not going to get one vaccine that finds this a global pandemic cure for, a cure for everything. So I think and I'm not being doom and gloomy when I say this, but I think as advocates and as community people, we need to work on the worst case scenario to protect people, not on the optimist, we're going to be all right in 6 months' time, because actually, I very much doubt we are going to be all right in 6 months' time.
I don't know. I try to be optimistic.
I'm with you. We need to keep that optimistic.
You might be right. I just thought of something else in terms of sexual risk. So, although I mentioned that the saliva is likely to be infectious based on viral load, and we know that for a short period, and including whether or not you've got symptoms. But the other thing that happens with sex is that you breathe more heavily. You know, so that you just, hopefully there's some level of excitement where your heart is beating faster and you're forcing out more air, and so that the air in the room becomes more infectious as well. You know, and those two things together, you know, if you're ruling out both those things as risk factors during sex, it sort of rules out the point of having sex in the first place, you know, generally speaking.
I think these are the kind of the practical things that we're juggling with. Like, you can kind of write down on paper, like, oh, this is what the messaging should say. There should be no kissing. You should be careful with rimming. And then it's like, but what's actually going to happen when someone's decided to get someone around and they knock on the door and they open it? What's the reality kind of thing? And we're hoping that some of those, like I said before, some of the community surveys might, and some of the universities doing, might answer some of that. What are people being careful, or are they is their risk perception much lower?
I'd say that even if you have no physical contact, and even if you stayed 2 meters away from someone in the same room, but it was getting very hot and excited, you will be breathing more deeply, and you'll be, you know, if you're infectious, then the particles are likely to be in the room. And I'd reference the Mark Mascalini paper talking about infectiousness not just from coughing and sneezing, but just from breathing.
That's the thing we've said that as well. I mean, it's just something like I live in an apartment block, and it's like people are kind of moaning about not sharing the lifts and stuff, and I'm like, well, if someone's just coughed in it, got out, and you've got in, you're still screwed, sort of thing. Is this?
Yeah, it'll hang around for, you know, if not 10 minutes, then maybe an hour.
Yeah.
Simon.
Yep.
Hi,
Simon. How are you doing?
I'm fine, thank you. And you?
I'm doing all right. Good to see you.
Yeah.
I need to pick up a little bit.
I'm okay. I had actually kind of something, two partner live in the same house, and being diagnosed, one is negative and the other one is positive.
Yep.
How can it be? The husband and wife, so the husband is positive, the wife is negative.
Just good luck or bad luck, and also time. And so, although you say the wife is negative now, if they share everything, there's a good chance that she could still become positive tomorrow. So in that setting where someone's definitely diagnosed, and that we know it's only going to be for a fixed period, 2 weeks maybe, or 3 weeks, I would separate the living areas in that flat. I would be really strict. I'd probably use face mask, you know, and if they and do everything, because you know you're going to overcome that. So one person lives in one room, the other person lives in the other room. You know, if you put the food there, and it's going to be very weird, but I'd try and protect your partner. If I was diagnosed and I was living with somebody, I'd go and shut myself in the bedroom, and I'd have the food left on a tray outside.
The other thing you talk about Africa, which is something very actually, myself, I'm worrying about my family in Tanzania.
Yep.
The president actually, funny enough, he ran away from the city, and he actually telling the community people to go to work, you know.
Yeah.
So Tanzania have not shut down.
Okay.
People are still continue with daily activity, which is really, really worrying. One of the MP something actually, he now came out and say everyone had to memory how this thing they put, you know, this thing that they put the pot and kind of steaming themselves.
Sorry, can you say that again?
They, you know, back in Africa, how they now doing things, putting, steaming themselves with those leaf and everything.
Oh, I see. Oh, this is the case from, is it Madagascar or Mauritius? There's a herb or plant.
Yeah. So
it's being bottled. And is it Mauritius or Madagascar? I'm not sure. But they are bottling it and selling it. And I don't know, nobody has had, I mean, I don't have any scientific stuff about it.
So Tanzania
I believe
now,
that it has some activity against flu symptoms.
yeah.
So we have, I mean, there's no data on that. We don't know any science behind it. It's just gone viral everywhere.
Exactly. Now Tanzania, that is what they have been told to do. Everyone actually to kind of using those leaves and actually steaming themselves. So I'm really, really worried. And I have seen some clips that people just collapse and die in the street.
Yes.
And that is something really, really makes me worry a lot about my family, my children back home in Tanzania, because the president has not taken this thing seriously, to be honest. And the bad thing, no one can say anything except the prime minister, I think, yeah, and the health department. Actually, only 2 people have to say. And I heard they say that you are not allowed to mention anyone who died. Just mention how many people who have been caught with COVID-19 and actually survived.
So the
so
best...
there's a really, really something is going on in Tanzania, and I'm worrying about my family, to be honest.
So the best thing you can do is be a really good source of accurate information. You can tell your family that this is serious, and you can give the same advice that you can say what's going on in the UK. You can say, you know, UK with all its infrastructure, you know, didn't do it quick enough. So it's going to be the same in every country, unfortunately, and that the plausibility of any herb helping is low. I've got other friends in other countries. I say, what's being said back there, you know, and there's various myths. There's an IAS, there's a WHO page that says myths about coronavirus, and one of them is that if I drink lots of water, I'll be okay. You know, and those things aren't going to help. The things that will help will be, you know, if you're washing your hands so that if you come into contact, you don't then transfer it to your face. That's the risk factor, and social distancing, and probably a mask. All those things are very useful.
Yeah.
And so tell your family to take it seriously, and to the best way things are to reduce the risks are the same as in the UK, really.
And the other thing is about actually Damian and Alex share about educate community. I think it's very, very important if we can now look at it, how we can get together and starting to raise this awareness in the community or in the organization, especially like, you know, Black African community. I think it's something that we have to look at and start it now.
Yeah, it's definitely, like, so the work that we're doing, we're looking at all different populations and communities and sort of like demographics, groups of people. And obviously with the national programme, our key populations that we work with in the UK are gay men and Black African men and women. So we're doing a lot of focus in those areas. Africa Advocacy Foundation, obviously one of our key partners in that as well. So we'll be linking in with you and Dennis and everyone and updating you all soon. So I was off yesterday because of the have meeting and everything, but we had a meeting with PHE then. So when I'm back in work on Monday, I'll have a bit of more of an update about what our next steps are. And then we've also got the network, which has been dealing with prevention as well as the support services, and that meets every Friday at 4:00. And yeah, you can either contact Sean or Kat at NAT about that, or myself and Joe can probably add anyone on to the. I've subscribed a few people to the Slack group forums where there's some information being shared. Mostly to help organisations. A lot of it's around support services, kind of helping each other out with helping those who are most vulnerable at the moment. But we've also been sharing the latest medical advice and that sort of thing. And there's been some prevention work as the support services have kind of got into a good way of working over the past month. It's now like the focus has slightly changed around prevention.
Yeah.
I mean, I've also heard just like anecdotal reports from friends and family who still go to markets and stuff. That where a lot of Black people do their shopping, like Dalston Market and so on, where people are not observing social distancing and argue with somebody like, can you just move away from me while I do my shopping? So I think there is a lot of educating that needs to be done.
Yeah, definitely.
Yeah.
I think it's like I've been doing most of my shopping in Aldi in the Arndale Centre in centre Manchester, and even there's people in there with masks, and they're in the store, they're fine, and as soon as I'm like at the till, they're kind of like right up behind me, and I'm just like, what is the point of you wearing that mask, keeping away from everyone, of you then getting impatient for the last 5 minutes?
Yeah.
So in Waitrose, weeks and months ago, all the pasta went, all the rice went, all the spices went, all the olive oil, all that sort of stuff's gone. If I go 100 yards down the other direction and just go to any of my East London shops down in Whitechapel, then they've got 25-pound bags of rice piled up to the ceiling. They've got spices that you want, for days going out there, but absolutely no social distancing.
Yeah.
Go into a shop and there'll be 30 people in there and everybody's shopping as usual. And so
Yeah.
if you want a lemon from Waitrose, they went weeks ago, you go down to the East London Indian shops and they're piled up and you can get everything you want, but there's different approach to social distancing.
Can I just pick up on something about the support services? That I think we've talked very much about community support here, but I think one thing that's really missing is the medical support. What support is being given to nurses and doctors that are living this absolute nightmare? And I'm saying that having, call it support if you want, three nurses who are absolutely distraught at what they are seeing. And I think, us that lived through the early 80s and 90s epidemic, for some of us, this is reliving a lot of what we saw back then, but on an even bigger scale to some extent. And I think, how do we support these nurses and doctors, particularly from the HIV community, who have been thrown in at the deep end? But not just the HIV community, from all, my cousin's wife, she's a nurse in diabetes. And because she heads up the diabetes clinic, she has been thrown into COVID.
I've had quite a few contacts, both emails and telephone calls, because of my name being out there as being Beaver Communications, from nurses, Damien, and from nurses who are themselves HIV positive. I had a long conversation with somebody yesterday evening and then sent them some stuff through, and they came back this morning. Because if you're HIV positive, when you're being asked to work in ICU, you're naturally going to be more afraid than someone who is...
I disagree with that, Joe. No, I disagree with that. No. You're not going to be more afraid, because you're going to be, if you're HIV positive working in intensive care, for a start, you're going to be undetectable. For a second, in intensive care, you are certainly going to have the right protective equipment in intensive care.
Well, Damien, my experience from people is that they certainly don't feel the way you're describing. And I can understand that, totally understand it. I assume often that people who are medically trained will have a greater level of knowledge, but I frequently find that in fact sometimes people like us in the community maybe do have a greater level of knowledge because we spend so much time reading about it and going through it with others. So, I mean, basically you can't make assumptions, but I do agree that everybody, nurses, pharmacists I've had as well, are very worried and do need to have the right information and to have an amount of reassurance. And as Simon has been saying, the evidence that we have at the moment is frankly scanty at best, because this is new to all of us. So
yeah, I mean, we're not really. I'm not really talking about the evidence here of what's happening. I'm talking about the actual people that are living this. How are they offloading this? Where are they offloading? And are they taking this home with them? Certainly, one of the people that I spent 3 hours on the phone while this person sobbed, and I mean sobbed, of what they'd seen.
So I think your main point, Damien, is absolutely right. Is that as a community, we have a certain level of experience of dealing with serious illness and death and mortality and all that stuff, and those skills that we learn are useful now. And so HIV organisations should be able to provide some of this support. I do know that there are already some resources online for health workers in terms of dealing with stress, because I saw a lecture online yesterday about dealing with stress for health workers, and so actually the big point you're making is absolutely right. We've got some skills from our experiences that would be useful in this situation, and then another comment really is just that it's not just health workers. Is that so? One of the Q&As we had to iBase was somebody who works at a supermarket, and initially, they're self-isolating because of the advice they had about HIV, and they just want to go back to work with their colleagues and put their bit in for they want to know how to do that safely enough, whether or not they're at risk. So through all those professions, whether you're a bus driver or a health worker or work in a supermarket, people that are out there still in the broader community, which is where the risk is, will be balancing a level of stress versus responsibility. We need to make sure they have the protective equipment they need to do that as safely as possible. And then as the reach of people who are directly affected by COVID-19 in terms of losing people and becoming sick themselves, then yes, that's going to bring up all sorts of historical difficulties. I mean, I find that already. Even in terms of risk, what happens if I think I'm broadly safe, but then I'm not quite so safe, and someone sneezes at me in the supermarket? Do I then compromise people that I see later in the day?
Yeah. And I mean, this person that I'm talking about who sobbed for 3 hours on the phone, they didn't live through the AIDS epidemic. They've only lived through the COVID one, and all they've said is all they can smell is death, because they've seen so much of it.
So referral to counselling and psychological support and support that comes is just as important now. They should be encouraged to access those services which should be available to NHS staff. Flag it, if they're a nurse, flag it with the union, the nurses union and the HIV union they're connected with.
Yeah. I'm going to have to go, everyone, but it was great to see you.
Yeah, me too.
Thank you, Alex.
Right. Thanks very much, everybody.
Thanks, Henry and Alex, for organising this.
Thank you. All right. Take care, everybody. Have a good weekend.
Okay, you too.
Bye.
Bye. Thank you.
Thank you, Memory.
Thank you, my dear.
Yes, good to see you.
Good to see you too. Okay, I'm going to end the meeting now and you all disappear.
Yeah, okay, thanks.
Okay, bye.
Bye, my dear.